Hello, this is Elena Coucher. I will be presenting Chapter 33, The Preschooler and the Family. So when we're talking about the preschooler, we're looking at ages 3 to 5 years. What are they going to do? They're prepping for the most significant lifestyle change. They're going to start going to school. Uh, they practice cooperative interaction with other children, experiences of brief and prolonged separation, use of language for mental symbolization, and increased attention span and memory. It's a dramatic time of change for the 3 to 5-year-old, especially in the areas of physical growth. It slows down from the rapid growth of infancy. Emotional and social development exhibits in gender recognition and more socialized playing from parallel, which is the side-by-side play, progressing to this is my best friend. Cognitive development or thinking and reasoning skills progress from simple to more complex and understanding of time, letters, counting, and colors. They follow more difficult commands, and play becomes more inventive and imaginative. Language develops more rapidly. Age 2, they have a vocabulary about 50 words. Age 3, that increases to about 150 to 200 words, and it can follow two-part directions. 4-year-olds use longer sentences and can describe events, while the 5-year-olds can carry on sometimes a lengthy conversation with you. Sensory and motor skills become more refined from walking upstairs, kicking a ball, and drawing simple strokes to tumbling skills and drawing figures of people. They also learn to dress themselves and handle toilet needs independently. So as the physical growth slows and stabilizes, during that time, the motor and social skills are multiplying by leaps and bounds. The average weight is about 5 pounds. Average weight gain is about 5 pounds a year, and about 3 inches in height has grown each year. They become more slender with less of the sturdy potbelly look of the toddler. This increased stature results in increased agility and performance of tasks such as hopping, jumping, riding a tricycle, and even bicycles. They begin to learn to skate and swim. Their organ systems are mature and they can withstand a little stress and change. And then most children will toilet train by this point, of course. So age 3, they walk, they run, they jump, they climb well. They're proficient in these areas. They can get away from you quickly. Ride tricycle, walks on tiptoes, balances on one foot for a few seconds, and does broad jumps. They also like to tell you at this time that they can jump higher than you or they can jump farther than you. These tasks usually develop by the time they're 36 months. They have that increased eye, hand, and muscle coordination. It's pretty evident in many areas, and the children begin the drawing and building with blocks and dressing. The 3-year-old should be able to do the walking, the running, the jumping, and the climbing well. But falls are very common in this age group because they do all these wonderful gross motor skills proficiently, but they often don't pay attention to what they're doing. Of course, they like to ride this tricycle. They're understanding how to, when they push the pedal, that they are propelling forward. So what can the age of the 4-year-old do? They can do all the things that the 3-year-old does, but they're still refining those gross motor behaviors. And the children with these new skills often begin participating in team sports such as t-ball and soccer. They are able to skip and hop on one foot very proficiently. They can catch a ball. They'll throw a ball up in the air and they can catch it, and it's a great task for them. They're really excited about the fact that they can do this. The 5-year-old, of course, can do everything that the 3-year-old and the 4-year-old were doing, but they can skip on alternate feet now. They can jump rope. They begin to skate. They learn how to swim at this time. They are becoming very, very proficient in what they do. They're starting to pay a little bit more attention to what's going on around them, and so that they're aware of their surroundings and environments. So Table 33.1 is on page 958, addresses the fine motor skills of our school-age child, the drawing, the dressing, the writing alphabet letters. Fine motor skills, those are small muscle movements of the fingers that help a child perform the school readiness activities such as painting with a paintbrush, cutting with scissors, drawing and writing using a pencil or crayon correctly, holding and manipulating small objects, holding and using a knife and a fork. They can do craft activities. Between the ages of 3 and 5, children usually demonstrate rapid gains in fine motor manipulation, finger dexterity, and tool use. Fine motor skills don't develop overnight, but take time, patience, and practice. Age 3, they're going to build tower of blocks, 9 to 10 blocks high. They're going to draw a circle and perhaps a few sticks, but cannot draw a person or a stick figure. And it may or may not have facial features. Age 4, they successfully use scissors to cut out a picture. They copy a square and can trace other shapes. Draws a stick figure with about 3 parts. Begin to tie shoelaces at the age of 5. Their stick figure gets more parts by this time, 7 to 9. They're beginning to print a few letters, numbers, and words, and probably at this point it's going to be their first name. A major, major task. This is going to school, because at this point they're controlling their bodily functions. They experience the brief and prolonged separation. They're able to interact cooperatively. They have increased use of language and increased attention span and memory. So the preschooler at age 3 to 5 has these essential achievements that need to be obtained before the major task of going to school. We want them to be able to use the bathroom on their own. That's why we have the control of bodily functions. It's not feasible to think of a 3-year-old going to or a 5-year-old going to school who is not potty trained yet. They must be able to function independently for brief and prolonged amounts of time. They must be able to cooperate with not only their peers, but also with other adult figures. They must be able to communicate their needs by means of language and social behaviors, and they must have an attention span that lends itself to sitting quietly and studying or learning. They must have the memory adequate for learning that is required in school as well. There's Erickson again. This is the initiative versus guilt. Increased muscular, mental, and language abilities set the stage for more activities and questions. There's a great curiosity and openness in learning. If anybody has ever experienced a 3-year-old, you'll say, no, we can't do that. But why? Because, and you try to explain why it cannot be done. But why? That's a really favorite word for a lot of 3-year-olds as they're heading into 4. Parents who take time to answer their preschoolers' questions reinforce their intellectual initiative, but parents who see their children's questions as a nuisance may stifle their initiative and cause them to be too dependent on others and to be ashamed of themselves. True story here. Not that I wanted to ever quiet my child for saying, but why, and asking a ton of questions, but most parents, after you've answered so many of them for a while, you start to say, just because I said so, be quiet, I'm done talking, all these kind of different things. My husband's grandfather, he was quite the older gentleman, and even at his age, and dealing with his own children and his grandchildren and then his great-grandchildren, he would tell us, but that is how he learns. He asks questions, he talks a lot, because that's how he learns. And it is true. They're never going to learn, and they're never going to develop if we don't answer the questions and encourage that intellectual part of them. Imaginative play is the basic activity of the stage. The preschooler explores and reenacts the different roles and activities of people, both real in their home life and fictional, sometimes based on television. I'm a superhero. And Erickson's theory, initiative versus guilt, is a psychological conflict of early childhood. It is resolved positively through play experience that foster a healthy sense of initiative and through development of a conscience that is not overly strict. When initiative is criticized or punished, the child learns a sense of guilt which causes doubt. It affects their ability to make decisions later in life. Play permits preschoolers to try new skills and cooperate with other children to achieve their common goals. Okay, so cognitive development, Piaget, we're talking about some pre-operational phase now. It spans 2 to 7 years. It's divided in 2 stages. There's the preconceptual and there's the intuitive thought. Preconceptual starts around ages 2 to 4, intuitive thought around ages 4 to 7. They start to shift from the egocentric thought to social awareness. They have the ability to consider other viewpoints. In that 2 to 7 year time frame, this phase is where the child begins to develop an increased understanding of the world. It is characterized by operations not being reversible, egocentric, and magical thinking. There's also an advance in symbolic and creative activities such as storytelling, pretend play, and drawing. The pre-operational child is much more capable of understanding his world, and most pre-operational thinking is self-centered, so that's why we call it egocentric. According to Piaget, a pre-operational child has difficulty understanding life from any other perspective than his own. In this time, the child is very me, myself, and I oriented. The stage is divided into 2 subphases, and I just told y'all when the preconceptual and the intuitive phase begins. In the preconceptual, the child sees the world only in relation to themselves. In the intuitive phase is when the child begins the intuition is used in thinking and problem solving then. You can look up table 32.1 on page 926. These are some characteristics of pre-operational thought. In the preconceptual stage, that age approximately 2 to 4 years, the child will react to all similar objects as though they are identical. At this time, all women might be mommy and all men daddy. This stage is marked by egocentrism, or the child's belief that everyone sees the world the same way that they do. It's their own point of view. They fail to understand the differences in perception and believe that inanimate objects have the same perceptions they do, such as seeing things, feeling, hearing, and their sense of touch. While at this level, a child's thought is transductive. This means a child will make inferences from one specific to another. This leads the child to looking at the moon and reasoning, my ball is round, that thing there is round, therefore that thing is a ball. Piaget's intuitive thought phase begins in the 4 to 7 year time frame. Children go through the intuitive period at that point. This is a period that's still characterized by the egocentric thinking. Perception is dominated and intuitive thought, which is prone to errors in classification. This stage is governed by perception rather than logic. The child fails to realize that when water is poured from a beaker into a tall, thinner beaker, that there is still the same amount of water. The child has not mastered conservation and can only focus on one aspect of an object at a time, and thinks objects are in a permanent state. Speech becomes more social, less egocentric, easy to believe in magical increase, decrease, and disappearance. Reality is not firm. Perceptions dominate their judgment. In moral ethical realm, the child is not able to show principles underlying best behaviors. One of the main transitions between these 2 phases is a shift from totally egocentric thought to social awareness and the ability to consider other viewpoints. Our cognitive task at this time, language mirrors the general mental activity of preschool children. A characteristic of 4 to 5-year-olds is their egocentrism, of course, their tendency to view the world from their own perspective. For example, if asked, why does the sun shine? A typical response from a preschooler might be, to keep me warm. This self-centeredness is due to the child's mental inability to see things from another point of view. Causality resembles logical thought, and preschoolers' understanding is limited. Concept of time is not completely understood. They understand time in relation to events that are familiar with, like meal times, favorite TV show time, church time, Just different things like that. Avoid yesterday, tomorrow, next week, or day of week, as preschooler does not understand those yet. Use expected daily events. Helps learn their temporal relationships, such as I will tell my 3.5-year-old grandson, if I say, well, Mimi's going to come pick you up on Friday. Well, is tomorrow Friday? No, tomorrow's not Friday. Tomorrow is Tuesday. I can't do that with him. I'll say, when you go to school, you're after you get out of school, Mimi will come get you. And so of course, I don't try to tell him things as far out in advance, because if I do, then he's probably going to drive his mother crazy. But you get the idea. So I'm not picking you up on Thursday. I'm going to pick you up on Friday. He's not going to understand what Thursday and Friday are. He's going to understand Mimi's going to come get you after school. We touched on magical thinking with the toddler. It does continue with the preschooler. Magical thinking, they often believe that their thoughts are all powerful, and they may cause things to happen. They believe they have magical powers and can make something happen by thinking or wishing it. If something does happen, they feel it is their fault because they wished it. This places them in a vulnerable position, especially if a tragedy happens in a family. They think they caused it by thinking bad thoughts. Their literal thinking also causes them to be vulnerable. Caution parents to not say the child is bad if they did something wrong, as this kind of a labeling may affect the child's self-worth. Due to magical thinking in this stage, the preschoolers are in, they may feel that bad things that happen, such as being abused, is their fault as well. So, we have to be careful of the wording that we use with preschoolers. Moral development. Moral judgment is at a basic level in the preschooler, and behavior is based on freedom or restriction. At age 2 to 4, this is called the punishment and obedience orientation. Whether action is good or bad depends on the results of the reward or punishment. At 4 to 7 years of age, the stage of naive instrumental orientation, in which actions are directed towards satisfying their needs and less than satisfying others. So the levels of moral development. There's a level 1, the pre-conventional morality. Stage 1, the individual obeys rules in order to avoid punishment. In stage 2, the individual conforms to society's rules in order to receive rewards. Kohlberg says it follows a pattern. In early stages, the child simply tries to avoid punishment. An older preschooler proceeds through a very self-centered stage with decisions based on self-satisfaction and what's in it for me actions. In later stages, children develop a greater concern for being good and doing what is socially acceptable. Spiritual development. Faith and religious practices are learned from the parents or caregivers. Preschoolers have a concrete concept of God, who is often like an imaginary friend, powerfully and permanently influenced by actions and stories of the visible spirituality of related adults. They'll imitate these practices without completely understanding them. They understand simple Bible stories, and they can memorize simple prayers. Children often interpret illness as a punishment from God. Now let me just tell you something about that concrete, who God or Jesus is. My grandson, his mom and dad would point up towards the ceiling, and they thought that they were just showing him, Jesus lives up here, but he's really all around us. And it was totally confusing to him for a long time. He thought Jesus lived in a ceiling fan. So, I mean, I thought that was a pretty funny thing. But you just have to think about where toddlers are and where the preschoolers are and how they actually perceive things. Development of body image. Preschoolers are noticing differences in skin color and racial identity. They're also starting to notice smells. This is the time when you're going to be in a store and they're going to say, "She stinks." They're vulnerable to learning prejudices and biases. They also know the meaning of pretty and ugly and reflect the opinions of others regarding their own appearance. Because they are concrete thinkers, They often have very literal fears related to medical procedures such as drawing blood or receiving injections. They may think that all their blood will leak out if a hole is stuck in their skin. So bandages are important to keep things in. The preschooler will also cry loudly in protest to shots. They may even scream, and they're definitely going to voice their displeasure. All right, so development of sexuality. Sex typing, the process by which an individual develops the behavior, personality, attitudes, and beliefs appropriate for his or her culture and sex, occurs during this period. The most powerful influences in a child's life comes from childbearing practices of their parents or caregivers and imitation. They may play dress up and imitate mommy and daddy. Sexual exploration may be more pronounced, and often questions about sexual reproduction begin at this age. Sexual feelings are clearly present before this preschool years, but become more obvious now. Handling the genitals for pleasure peaks at about 2.5 years of age before becoming more private, and exploring the genitals of others is also very common. We don't need to condone it, but we don't need to condemn them for it. The solidification of gender identity and gender role identity occurs during this preschool period. Parents are often dismayed by their child's gender stereotyped play, even when the family has espoused less traditional roles. The social development, separation, individuation process is completed, and the preschoolers have overcome much of the anxiety associated with strangers and the fear of separation. They still need parental security, guidance, reassurance, and approval. Throughout the preschool period, any child from age 2 to 5 years could regress momentarily to total infantile dependence, such as going limp and saying, "I'm a baby." Then quickly show independence, declaring, "I can do it myself, I'm big boy," even when the task is something he or she has never done before. They can cope with changes in daily schedule, however, find comfort in familiar objects such as their doll or their photo of their family, favorite blanket, those kinds of things. Use play to work through fears, anxieties, and fantasies, especially if using proper tools like dolls and puppets. It's also, you think about how we might interact with preschoolers in the hospital when we're talking to them about procedures. Do you think that if we show them a video on how the procedure is going to go, that they're going to understand it? Probably not. Well, your sister had this procedure done, and that's not even something that we need to do. Usually, if you work at Children's Hospital, they have dolls there that they use for the role play and teaching what's going to be going on during a surgical procedure on that child. An explosion of speech and language development takes place between ages 2 and 5. A child's vocabulary expands from around 300 words at age 2 to about 2,100 words at age 5. Age 3 and 4 form sentences of about 3 to 4 words. They can name familiar objects such as animals and parts of the body. They enjoy musical or talking toys or dolls and imitate words proficiently. They may talk nonstop whether anyone is listening or not. It's just one of those things they do. They enjoy reading picture books with a parent. By the time they get to 4 and 5 years old, they have longer sentences. They can follow simple directional commands. Put the crayons in the box. Put the ball in the basket. Table 33.1 is about language, so that kind of can give you some ideas there. They obey prepositional phrases under, on top of, beside, in back of, or in front of. By the end of 5 years, a child can use all parts of speech correctly with verbs, nouns, prepositions, and adjectives. In addition, the preschool child may learn many language concepts, such as different names for the same object or person. The concept of opposites, and can describe an object by its composition. A spoon is made of metal. The personal social behavior, the ritualism and negativism of toddlerhood is diminishing for the preschooler. They're able to verbalize their autonomy and requests for independence. They want to do everything by themselves. Everything. By 4 or 5, they require little assistance with dressing, eating, and toileting. They may put their shoes on the wrong feet or a shirt inside out, and they should master tying their shoes by the end of 5 years old. They can obey warnings of danger. A preschooler is also very sociable and wants to please. By the beginning of school age, they begin to challenge parental values and lean more toward opinion of their peers. Play. They're going to do associative play, group play without rules, imitative play, imaginative play, and dramatic play. It is through play that much of children's early learning is achieved. The physical, socio emotional, and intellectual development of children is dependent upon activity. Through touching, manipulating, exploring, and testing, children find out about the world around them. An associative play occurs when children play with each other. They share similar materials and activities in an unorganized way. Boys playing is the sand with heavy equipment. One of the most obvious tasks of developmental progress for the school-age child is learning to interact happily with their peers. At the age of 2 years, most play still is parallel, although children frequently look at peers and copy some of their actions. By the age of 3, children should have mastered aggression and should be able to initiate associative play with a peer. Children engage in different types of play depending on circumstances and particular needs. Types of play range from inactive observation to participation in group play requiring planning and cooperation. Pretend friends are very common in children up to the age of 4. These fantasy figures often fill the role of the scapegoat for misbehavior, demonstrating that the child recognizes correct behavior but cannot always do it the right thing. Dramatic play, I'm the mommy, you be the baby. They dress up, do cops and robbers, etc. Fantasies are real in the minds of children who are engaged in dramatic play. Children can switch roles from animate to inanimate objects with the blink of an eye. They have carefree, creative, dramatic play that promotes cognitive development and helps children learn how to share, communicate, and cooperate with each other. Through role-playing, children also learn how to develop empathy for others. The TV can have a negative effect as well as positive effects. So depending on what is being watched and how much, educational media may even be kind of beneficial. Preschool or daycare, they have structured learning that is not as important as social climate. The type of guidance and attitude toward children that's fostered by the teachers. Teachers should be knowledgeable about childhood growth and development to provide proper activities, quiet play, active outside play, group activities, creative play, snack and rest time needed for appropriate learning and development. Parents need to always evaluate a preschool before enrolling their child. What parents should look for: a licensed and regulated program, plenty of room to run and play, sturdy toys, teacher-to-child ratio, outdoor areas for play, teachers trained in CPR, teachers trained in early childhood education, ability for parent to drop in at the school anytime. What about school readiness? Is a child ready to enter a social and educationally based environment? We have to look at the social maturity, especially their attention span. That's a major indicator right there. The school should help the child gain more independence, adapt to the social world with peers, teach rules and consistency, challenge a child's imagination and creativity. A developmental screening may help identify if a child is ready. Parents' attitude towards learning plays a major role in how the child transitions to the school, though. Children in daycare, especially under 3 years of age, do have more illnesses, especially diarrhea, Hep A, meningitis, otitis media, and respiratory tract infections. It's also important that good hygiene is encouraged after using the bathroom, when coming in from outside play, and before eating. Inquire about their sick child policy and the cleaning of equipment and toys. When do they do that? How do they do that? Take the child to visit the preschool and meet the teacher and some of the children before the first day. Sex education. Find out what children know and think. Where did I come from? May or may not be a question about sex education. Be honest and give them correct information and pronunciations. Although they may not comprehend and only remember parts of the information, avoid over answering the question and give them small bits of information that they are developmentally able to absorb. Remember, sexual exploitation, um, sexual curiosity is common and often involves other playmates at this age. Parents should use a positive approach and neither condemn or condone the behavior. Masturbation is the most common at the age of 4 and adolescence and is normal developmental behavior unless it is excessive. Emphasize to the child that this kind of play is private and is not socially acceptable behavior. Do not punish them for it. May need to investigate further if the child is obsessed with the activity, acts out sexual intercourse, or mimics adult sexual behavior. That would be some warning signs. Parents should not worry if the child is social and outgoing, though. Fears. It's normal. I mean, we all still have fears now. It's normal for a preschooler to feel fearful. Some 3 and 4-year-olds are frightened of very specific things like bugs, dogs, the dark, or clowns. Certain fears are particularly prevalent during the preschool years because a child's highly active imagination. It may make him worry about making make-believe creatures. His or your health, death, um, disaster, pain. Being hurt is another common fear. That's why your preschooler wants to cover up even the most minor scratch or cut. We want to encourage parents to acknowledge their child's fears. They may seem silly and irrational, but they're very real and serious to him. Reassurance and comfort help them learn that it's okay to have fears and that it's best to deal with them. Involve the child in finding a method to deal with the experience. Maybe a night light to scare away monsters, maybe a monster spray to spray the room and under the bed. Desensitization, exposing the child to the feared object in a safe environment. Watch other children play with a dog. Introduce gradually. Don't force the child to face the object of their fear. Another characteristic of the preschooler thought is animism. That's evident when children credit inanimate or lifeless objects with lifelike qualities such as feelings and thoughts. To the young child, things that move are alive, like a piece of paper blown by the wind or a flowing stream. Animism has its own charm and occurs frequently in children's stories and fairy tales. You know, a familiar example is a scarecrow who comes to life in The Wizard of Oz. Sometimes children cry if a favorite stuffed animal is kicked or callously tossed out of the way. This is a prime example of animism. The stuffed animal is hurt by such careless abuse. Stress. Beginning school can be very stressful for a preschooler. Stress is a normal response that everybody feels from time to time. Some stress is helpful because it motivates us. Stress is bad when it interferes with daily activities, relationships, and health. Even very young children can experience stress. So how do you know if your child is stressed out? So some stressors: birth of a sibling, divorce or separation, relocation, illness. The evidence of stress in this preschooler, you're going to see increased crying, sleep disruption. For the verbal preschooler, there's evidence of stress that could include acting out behaviors, including defiant speech and actions, anger problems, stomach aches or headaches, decreased appetite, inability to control their emotions, nightmares, clinginess, and whining. So aggression, there's a lot to say on this slide. Aggression, that's behavior that attempts to hurt a person or destroy property. It is influenced by biologic, sociocultural, and familial variables. Different from anger, but anger may be expressed through this aggression. Hyperaggressive behavior in preschoolers is unprovoked physical attacks on other children and adults, destruction of others' properties, frequent intense temper tantrums, extreme impulsivity, disrespect, and noncompliance. Some aggression is a normal part of a preschooler's development, though. It's hard for parents to grasp a hold of. Factors that increase aggressive behavior: gender, males are more overtly aggressive than females. Frustration, sometimes children lack a grip on a vocabulary. Pushing and hitting are the closest ways for them to express their frustrations, and they demonstrate their lack of social skills through pinching, biting, or any other form of aggressive behavior. Modeling of other siblings or playmates, violence in the home or on television. There's a direct correlation between media exposure and physical and relational aggression. Reinforcement. If a child feels neglected, he will try to get attention in any form. An arrival of a new sibling can make him feel resentful or neglected. He may just retaliate by pushing the child. So what do? You got to respond quickly. Try to respond immediately if you see your preschooler getting aggressive. Remove him from the situation for a brief timeout. 3 or 4 minutes are a lot of time for a preschooler. The idea for a timeout is for him to connect his behavior with the consequences and figure out that if he misbehaves, he will be the sufferer and miss out on all the fun. React in a consistent manner. As much as possible, respond to the aggressive acts the same way every time. Eventually, it will sink in. Then if he gets a timeout, he misses out on all the fun. Monitor their electronic viewing. Avoid TV programs, computer games, etc. with violence. I think that's probably that should be at the top of the list. Reward the good behavior. Rather than paying attention to your preschooler only when he misbehaves, try to catch him being good. Some children have more trouble with aggression than others, and sometimes an undiagnosed learning or behavior disorder is behind the frustration and anger. Speech problems, disfluency, stuttering, stammering, that occurs because ideas are able to come to the mind faster than the toddler's limited ability to express them. More common, though, if a toddler is stressed or excited. Give the child your full, prompt attention as he or she speaks, and do not comment or criticize the stuttering. Speak slowly and clearly to them. Those are some key things that we can use when we're talking to the child that stutters. Excuse me. Dyslexia, this is an articulatory disorder in which very often children do not pronounce the sounds clearly, or they replace one sound with another. K may be replaced by T or G or replaced by D. Instead of water, it may be something like lauder. I don't know. My son would not say his L's very well at all. So instead of laughter, it was laughing. Another thing was he would come down the hall and you'd say, "Samuel, come here," and he would say, "I'm pumming." So he had a lot of these things that were going on with him. If the stuttering is accompanied with other signs such as tics, grimacing, extreme self-consciousness, or if the stuttering persists longer than 6 months, we consider having the child evaluated by a speech pathologist. So how do we promote optimal health during the preschool years? Has anybody fed a toddler? Sometimes they are very, very picky eaters. Healthy nutrition during childhood should include eating a variety of foods. We want their caloric intake to be about 1,400 to 1,600 calories per day. Fluid requirements, approximately 100 meals, depending on activity and climate. They are definitely picky eaters. The amount of food that they eat varies greatly from day to day. You're going to have one that's going to sit down at the table, and that day he's going to eat everything on his plate. The next day, you're going to give him the same thing for lunch, and he's going to say, "I don't like it. I don't want it." But on the same note, obesity in young children has increased dramatically. They need to have structured meals. We need to reduce their sugary, sweetened drinks like sodas or fruit juice. If they don't like to drink plain water, it's good to get some of the Crystal Light and maybe put into their water. It adds just a little bit of flavoring, and they tend to like that. They need about 16 ounces of milk a day. It needs to be whole, 2%, or 1%, depending on the weight. Protein requirements increase with age. A preschooler needs 13 to 19 grams a day, so about a half to 3/4 of an ounce per day. Avoid obesity, avoid fast foods. We don't want to give them high fat and high calories. Don't use sweets as a reward. Do not require a clean plate. Preschoolers sleep about 10 to 12 hours per night, but there's no reason to be completely rigid about which 10 to 12 hours they are. If a 5-year-old gets adequate rest at night, he no longer needs a daytime nap. Instead, a quiet time may be substituted. Most nursery schools and kindergartens have brief quiet periods when the children lie on mats or just rest. Importance of play in a preschooler development can't be overemphasized. We have to provide a safe environment. That's important. Screen time, that should be limited. And not screen time, you're talking about the TV, computer, video games, handheld games. Sleep problems occur. Nightmares may haunt preschoolers in particular. This is an age when normal fears develop and imagination peaks. They may wake up crying and fearful, moaning about monsters and witches, and have trouble falling back to sleep. Nightmares can result from listening to a scary story, watching a frightening or exciting television program, or from being overly tired, anxious, or stressed during the day. When a child wakes up from a nightmare, they can often remember their dream and talk about it, so they're going to seek comfort. Night terrors are sleep disturbances in which a child suddenly bolts upright in bed, cries, screams, moans, mumbles, or thrashes about with their eyes wide open, but is not awake. Because a child is having a night terror and they're not really awake, they're unaware of others' presence and isn't likely to respond to anything said to them. And they're certainly not going to respond to you grabbing hold of them and loving on them either. Assess the problem, including any cultural practices, before recommending solutions. They need a consistent bedtime routine, helps the child to slow down and reduce the resistance for going to bed. Do not give in to attention-seeking behavior. Take child into parent's bed or allow to stay up past the bedtime. Parental consistency is most important. Other things you might do: a nightlight, favorite toy, drink of water at the bedside. Deciduous teeth, also known as baby teeth, primary or milk teeth, are the teeth that children have due to the fact that infant jaws are too small to accommodate adult-sized teeth. By the time a child is 3 years old, he or she has a set of 20 deciduous teeth, 10 in the lower and 10 in the upper jaw. Each jaw has 4 incisors, 2 canines, and 4 molars. The purpose of the molars are to grind food, and the incisors and canine teeth are used to bite into and tear food. By the time the average child is 6, the jaws and jaw muscles have grown in size and strength, paving the way for the arrival of permanent adult teeth. A child's deciduous baby teeth are extremely important because they serve the following critical functions. They allow your child to chew naturally nutritious foods like fruits and vegetables. They are involved in speech development, and they help the permanent teeth by saving space for them. In addition, children with healthy teeth also have a better chance of general health because disease in the mouth can endanger the rest of the body. Good oral health means preventing cavities. That's the most common disease in children. Cavities form when the bacteria in your mouth ferment the sugars in the food into acid, which eats away at the teeth and causes holes. These cavities can be prevented when you know the risk factors and recommend dental care practices. Hygiene is a major contributor to healthy teeth. Parents still need to supervise and/or brush the preschooler's teeth. Kids can also practice flossing as early as age 3. Parents are encouraged to help their children to floss, or parents are encouraged to help floss their children's teeth either with regular floss or with handheld disposable flossers. And baby teeth are particularly prone to decay between the teeth due to their anatomy and thin enamel, so flossing is very important. Diet is one of the biggest factors in the formation of cavities. We have to limit carcinogenic foods, sugary, starchy, or sticky foods. And trauma to the teeth can be very common from falls and should be evaluated as soon as possible, related to the need for preservation of space for secondary tooth or teeth. Injury prevention. Preschoolers have improved coordination, growth, and fine motor skills and balance, so they do have less falls. They're less reckless, listen to parental rules, and more aware of potential dangers. They put less things in their mouths, but poisoning is still a danger. There's an increase in motor vehicle versus child accidents related to playing in a parking lot, street, driveway, riding bikes, trikes, running after balls, or forgetting safety when crossing the street. Emphasis is now on education concerning safety and potential hazards and on appropriate protection. Excuse me. Parents should role model by setting examples of safe behaviors. If they're going to ride a bike, they need to wear protective gear as well. Helmets, elbow and knee pads, those kinds of things. Preschoolers are imitators and will follow their role models. You can look at Table 32.4 on page 942. That has your injury prevention. Water safety, swimming instruction enhances a child's safety. Children playing near water need constant supervision. Poison, continue to place toxic substances out of reach. Dispose of unused medication. Guns in the home, of course we want to keep ammunition separate from the gun. Use a trigger lock on the gun and store the gun unloaded in a locked closet, locked box or cabinet. Listen, strangers, that's kind of important. Not all molesters are strangers. Alert children to dangers without frightening them. Make sure they know there should be no secrets between you. Tell them to tell you if someone makes them feel uncomfortable or asks them to do something wrong. In addition, teaching the preschooler some safe words to use in case of an emergency, warning against a stranger danger, and telling them how to call 911. Those are all personal safety issues that should be discussed with the family and taught with to the toddler. Anticipatory guidance, care of the family. Child care focus shifts from protection to education. Injury prevention shifts from protection to education. School entry is an adjustment, not just for the children. It's also an adjustment for mom and dad. Children begin questioning previous teachings of parents, and they begin to prefer companionship of their peers. So what to expect from your preschooler? There is some family-centered care and guidance during the preschool years that's located on page 965 that you probably should take a look at. During the second half of the 20th century, a new process called immunization was introduced on the wide scale. This led to global eradication of smallpox, elimination of polio from the U.S., and has almost eliminated tetanus, diphtheria, mumps, and congenital rubella. Immunization has greatly reduced the incidence of measles, pertussis, and meningitis. Millions of deaths and other tragedies have been prevented, and we all know that a lot of times there are some people out there who choose not to immunize their children, and they do so for fears that are unfounded. So we really need to teach our moms and dads about immunizations. So when we're talking about taking care of the preschooler, we talked about immunizations, but we want to prevent the spread of communicable diseases. And we have to be familiar with signs and symptoms of infectious disease, provide appropriate care and interventions, identify the agents is important in reducing and preventing the exposure and spread to individuals who are susceptible. So some signs may be first signs of rash or sore throat. Communicable diseases are transmitted by direct or indirect contact, vector, or airborne. When the nurse suspects a communicable disease, assessment must include recent exposure to the infectious agent, prodromal symptoms. Do they have a rash or fever that indicate the onset of the disease? Their immunization history. Have they been fully immunized? And a history of having the disease. Have they had the documented case of the disease? Knowing immunization history and a history of potential exposure to infectious agents is very vital. Prevent spread of disease. The primary prevention is immunization. We want to control the spread of disease to others. We want to reduce risk of cross transmission of organisms. We want to make sure we follow infection control policies, and definitely do hand washing. Is it just us? No, we need to teach this to the moms and the dads and the children. Always, always include hand washing to prevent airborne spread. I teach them to cover the face with the tissue when sneezing or coughing, and prompt disposal of the tissues. Certain groups of children are at risk for serious complications. Those that receive steroid or immunosuppressive therapy, those with generalized malignancies, and those with immunologic disorders, infants younger than 1 year, and children with hemolytic disease. Example here for you. My son has been a asthmatic for years, and there was a time that he was on massive doses of steroids, and we had several different updrafts. We had short acting, we had long acting medications that we were using to prevent any asthma attacks. And so, he's had all of his immunizations. Well, I noticed one day, I was like, what is that on him? Got to looking a little bit closer, and I knew what it was. It was chicken pox. So I thought, this is just impossible. We've had the varicella immunization. So took him in to the pediatrician, and sure enough, there it was. And it happened, of course, because, and I didn't realize it at the time, but because of the increased doses of steroids that he'd been given, it pretty much made his immunizations at that point in time null and void. And so he ended up with chicken pox. Thankfully now he's a whole lot better. But we're looking at children that are like that. You don't even think about, oh, well, this child has asthma, so they're gonna be at certain risks. But they really are. When they have asthma, and we put them on extreme high doses of steroids to keep those lungs open, then they're at increased risk of it. Varicella, of course, the chicken pox. Y'all know it's contagious. It has an incubation period of 14 to 16 days. They're contagious probably 24 hours before the fever or 1 to 2 days before eruption of the lesions, until all lesions have crusted over. There's 3 stages of it. They have the papule, the vesicle, and the crust. It's very itchy, causes irritability. Can also get a secondary bacterial infection of the skin from it. We want to use Benadryl for the itching, keep the fingernails clean, cut short. The book may not say, but oatmeal baths are wonderful for that. They probably will be prescribed an antiviral agent such as acyclovir, and my son was given that because he was so high risk from the time that he had so many steroids. Erythema infectiosum, Fifth's disease. That's a mild rash illness that commonly occurs in most children. It comes in 3 stages. Their face is going to have that slapped face appearance that'll disappear in 1 to 4 days. They'll have a maculopapular rash on their extremities, and it'll last 7 days or more. Then the rash subsides but reappears if the skin is irritated or traumatized by heat, cold, or friction. The child is usually not very ill, and the rash does resolve in 7 to 10 days. Fifth's disease is caused by an infection with the human parvovirus, the B19. This virus infects only humans. Pet dogs or cats may be immunized against it, but these are animal parvoviruses that do not infect humans. The virus is probably spread from person to person by direct contact with those secretions, such as sharing drinking cups or utensils. Happens during school outbreaks. 10 to 60% of the students may get Fift's disease. Roseola, that's the agent human herpes virus type 6. It has an incubation period of 5 to 15 days. They'll have a persistent high fever for 3 or 4 days. Otherwise, they'll appear well. After the fever goes away, then the rash appears. The rash is first on the trunk, then the face and the extremities. In the second phase, the red rash with bumps that comes on, that's the hallmark of roseola, that the rash appears after that fever goes away. Although occasionally the rash may start while the child is still febrile, it may not appear until a little while after the fever breaks. Once that fever breaks, the child is usually not contagious despite the rash. There's no vaccine available for roseola since it is a virus. The best treatment is to keep the child's fever under control with Tylenol or ibuprofen and tepid baths. So measles, mumps, rubella. The first signs of measles are a bad cough, runny nose, fever, and red watery eyes. Sometimes at this stage, approximately 2 days before a rash, the small red spots with the blue-white centers appear inside the mouth. Those are complex spots. After 3 to 4 days, a rash begins with red spots first appearing behind the ears and at the forehead, spreading down the neck, arms, trunk, and finally the legs. The red spots can merge together on the face. Measles do not usually itch. They are highly contagious. Secondary infections include upper respiratory infection, otitis media, conjunctivitis. Treat symptoms and prevent secondary infections. Supplement with vitamin A for severe cases. They'll do a repeat dose in 24 hours and 4 weeks later. They can return to school approximately 4 days after the rash appears. Mumps, of course, a viral infection of the parotid salivary glands, and it's spread by droplet. These glands typically swell and become painful. Mumps may start with a fever up to 103. A headache and a loss of appetite. Well-known hallmark of mumps is swelling and pain in the parotid glands. Become increasingly swollen and painful over a period of 1 to 3 days. Then, of course, mumps in an adolescent and adult male may also result in development of inflammation and pain of the testicles. Let's see, rubella, viral infection characterized by mild respiratory symptoms and low-grade fever. Is followed by a rash lasting about 3 days and may be diagnosed due to mimicking other mild illnesses. We have diphtheria, tetanus, and pertussis. I'm not going to go through all of these. We kind of have discussed these in several other cases, but these are things that our school-age children might be at risk for being in a school environment. Scarlet fever, group A hemolytic streptococci. This is going to be transmission by droplet or direct contact. Incubation period is about 1 to 7 days. They're going to have sore throat, fever, vomiting, rash, strawberry tongue. Complications, they could get rheumatic fever, tonsillar abscess, or glomerulonephritis. Complications, rare with proper treatment. It can include acute rheumatic fever, otitis media, adenitis, pneumonia, sinusitis, meningitis, osteomyelitis, and glomerulonephritis. Nursing management, we got to treat the symptoms, fever, sore throat, lozenges, gargles, soft, cool foods and fluids. Prevent spread or reinfection. Discard toothbrush after about 3 days into the antibiotic treatment, and do not share drinks or fluid. Child maltreatment, intentional physical or abuse or neglect. It is estimated 794,000 children were determined to be victims of child maltreatment in 2010. More than 60% of child victims experienced neglect. Almost 19% were physically abused, 10% were sexually abused, and 5% were emotionally maltreated. Children ages birth to 3 years had the highest rates of victimization at 16.4 per 1,000 children of the same age group. Girls were slightly more likely to be victims than boys. More than one half, 57% of all reports that alleged child abuse or neglect were made by such professionals as educators, law enforcement and legal personnel, social services personnel, medical personnel, mental health personnel, child daycare workers, and foster care providers. Non-professionals would be friends, neighbors, and relatives submitted approximately 43% of the reports. Female perpetrators who are mostly mothers were typically younger than male perpetrators who were mostly fathers. Women also comprised a larger percentage of all perpetrators than men. Of all parents who were perpetrators, fewer than 3% were associated with sexual abuse. More than 3/4 of the perpetrators were friends or neighbors that committed the sexual abuse. Neglect is the most common, the failure of caretakers to provide for a child's fundamental needs and an adequate level of care. Neglect can include children's emotional needs such as lack of affection, attention, and emotional nurturance. Neglect typically concerns adequate food, housing, clothing, medical care, and education. It can also include lack of intervention or fostering of other maladaptive behavior, delinquency, or substance abuse. An important factor in neglect may be lack of knowledge of the child's needs, lack of resources, and caregiver substance abuse. Lack of knowledge to recognize emotional nurturing is vital for children is a very serious issue. There's also emotional and psychological abuse. That's the deliberate attempt to destroy or significantly impair a child's self-esteem or competence. Habitual verbal harassment of a child by disparagement, criticism, threat, and ridicule. Emotional or psychological abuse includes behavior that threatens or intimidates a child. Physical abuse, the deliberate infliction of physical injury on a child. Non-accidental trauma can be injury from abuse. The Child Abuse Prevention and Treatment Act of 1996 defines abuse as any recent or act or failure to act that results in imminent risk of serious harm, death, serious physical or emotional harm of a child that is less than 18 years of age by a parent or caregiver. Shaken baby syndrome. I'm not really going to talk about shaken baby at the school-age child, but it can happen with any of them, but you're probably going to see it more that's going to happen in your younger babies. So Munchausen syndrome by proxy. It's a fictitious disorder by proxy or medical child abuse is what it's called. Caregiver fabricates signs and symptoms of illness in the child, the proxy, to gain attention from the medical staff. Child may undergo needless and painful procedures and treatments and may be fatal to the child eventually. As a result, doctors, let me just tell you, typically the parent that's doing this feels satisfied when he or she has attention and sympathy of the doctors, nurses, and others. Children are typically preschool age and may die from the illness induced by the perpetrator. The diagnosis is very difficult, but would involve some of the following. A child with multiple medical problems that don't respond to treatment or that follow a persistent and puzzling course. Physical or laboratory findings that are highly unusual, that don't correspond with the child's medical history or are physically or clinically impossible. Short-term symptoms that tend to stop when the perpetrator isn't around. A parent or caregiver who isn't reassured by good news when test results find no medical problems but continues to believe that the child is ill. A parent or caregiver who appears to be medically knowledgeable or fascinated with medical details but continues to believe that the child is ill. A parent or caregiver who appears to be medically knowledgeable or fascinated with medical details or appears to enjoy the hospital environment. A parent or caregiver who is unusually calm in the face of serious difficulties with the child's health. a parent or caregiver who's highly supportive and encouraging of the doctor, or one who is angry and demands further intervention, more procedures, second opinions, or transfers to more sophisticated facilities. Factors that predispose to physical abuse: there could be parental characteristics, socially isolated parents, young parents, single parents, characteristics of the child, younger than 1 year, disabled or preterm, environmental, divorce, poverty, unemployment, poor housing, frequent relocation, alcoholism, or drug addiction. We need to talk about some sexual abuse, okay? The use, persuasion, or coercion of any child to engage in sexually explicit conduct, the simulation of such conduct for producing visual depiction of such conduct, such as the rape, molestation, prostitution, or incest with children. Incest is any physical sexual activity between family members. Molestation is a vague term that includes indecent liberties such as touching, fondling, kissing, single or mutual masturbation, or oral genital contact. Exhibitionism, indecent exposure, usually exposure of the genitalia by an adult man to children or women. Child pornography, arranging and photographing in any media sexual acts involving children alone or with adults or animals, regardless of consent by the child's legal guardian. Also may denote distribution of such material in any form, with or without profit. Child prostitution involving children in sex acts for profit and usually with changing partners. And pedophilia. It literally means love of child and does not denote a type of sexual activity, but rather the preference of an adult for prepubertal children as the means of achieving sexual excitement. We as nurses are going to see a plethora of these health problems. You're going to see children with STIs, bruises, wound infections, PTSD, suicidal ideation and addiction in a sexually abused child. I don't know what else to say about it other than it sickens me. And it's not something that I like to talk about, but it's something that we have to know is out there, and we have to be able to treat the children accordingly. Characteristics of abusers and victims. Is this something important for you to know? It probably is. Some of you are gonna go to work in an ER, and you need to know what these characteristics are. You need to be able to recognize them. Typical abuser is a male whom the victim knows, but may be anyone. Could be sibling and or mothers. All socioeconomic backgrounds. I believe there is a misnomer out there that low socioeconomic status puts people at greater risk of abuse, but that's not it. They're not any more of an abuser than what a high socioeconomic person is. People at all levels of society. 80% are adults and 20% are male adolescents. Many like to hold jobs where contact of children is available. Coaches, teachers, daycare workers. Offender may assault many children and many times before being caught. Incest, you have father, stepfather, uncle, etc. Usually is prolonged over many years, related to the girl's reluctance of retaliation and disbelief of authority of the mother. Many start with older child and move to younger as the older child matures or is unavailable. Boys can be victims also, less likely to report the abuse and suffer greater emotional harm. They may suffer from anal penetration or oral genital contact. Often offenders spend time with the victims to gain their trust before initiating any sexual contact. Most victims are then pressured into being an accessory to the sexual activity through various means and may be unaware that sexual activity is part of the offer. You can see this information on page 977 in box 33.1. Children do not tell out of fear of not being believed. the perpetrator is a trusted member, friend of the family, they will be blamed in the inability to verbalize what happened because they may be too young. They may not be able to do that. Nursing care of the maltreated child. Identify abusive situations as early as possible. History pertaining to the incident, evidence of maltreatment. You need to have a thorough physical exam. Observe the caregiver and child interactions. Pattern or combination of indicators that arouse suspicion and further investigation. And we have to protect the child from further abuse. We can't make promises. We can't tell them that they're never going to have to be around that person again. Um, and again, this kind of goes to the magical thinking. They may feel like that this is happening because they're bad. And so we have to encourage them and let them know that this is not their fault. They're not bad. That is the end of my preschooler presentation. I will see you in the classroom.